fumes that fixes the body, then add some chemicals. That makes the structure looks like feels like plastic, but the cells and the tissue are still you know like in living condition. For example, if I take a piece of this and make a logical slide, I'll still find myocardial fibers. It preserves it. The problem with these specimens is that you can't destroy them. You cannot burn them or cremate them because they produce toxic gases again. So a lot of medical schools have stopped using this. When I used to work in London, I used to teach for King's College, medical school there, and they used to have bodies, full bodies, plastinated, but then they couldn't get rid of these bodies after they were dissected. So the England, the laws in England, they said no, you can't bury them, you can't cremate them because these won't decay. They're plastinated, right? So they said, okay, we'll just dump them in the basement. They have few bodies in the basement that are plastinated. They're not using them anymore.
So they literally like last forever.
These things will last forever.
Wow.
Last forever. You don't have to do anything. Yeah. The good thing is, they don't smell. It's not messy. You can handle them. You don't need gloves. And you can take sections. Everything is still intact. That's a good thing. But you can't get rid of them. That's a problem. Okay. Last week we didn't do the coronary arteries. We didn't do the arteries. We didn't do the valves. Dr. Paulson will do that now. Yeah. You can add a lot of clinical information. Okay, that'd be great.
Just briefly.
Man, no problem.
There are two coronary arteries, left and right. That's pretty easy. We talk about the dominance of one artery to the other, and it doesn't have to do with the size of the artery. It has more to do with the distribution, especially distribution to the area of the septum between the ventricles. So you may hear dominant, if you work with a cardiologist, you'll hear dominant right, dominant left. 67% of us have dominant right coronary arteries. The left coronary artery is very short, it's about 1 centimeter long, and then it breaks very quickly into an artery that goes right down the front, if you look at your models, and then one that sort of goes over in a curve towards the left. One down the front is the anterior descending artery, very, very prone towards arteriosclerotic disease. There are some branches coming off of that, which are obtuse vessels coming off that. And again, that is running right in the intraventricular sulcus, which is between the two ventricles. But again, it is primarily supplying the anterior lateral aspect of the heart. The right coronary artery is a little bit longer, but it's pretty well hidden under the auricle, the right atrial auricle. But it is definitely longer. Of significance, the first branch that comes off of that, or branches, they go to the atrium, obviously the right atrium, and of that, one of those branches goes to the sinoatrial node. So again, you can get a sort of idea how important the right coronary artery is. The right coronary artery pretty quickly starts swinging, almost in the atrioventricular groove, around towards the right, between the atrium and the ventricle. If you turn it hard on the back side, you'll see the circumflex artery coming down around that curve from the left to from the right to the left. That usually has a pretty large branch called a marginal branch, and that's sometimes a very good artery to bypass to if the left anterior descending is fairly blocked. That left coronary then goes around the back of the left ventricle. It splays out into many branches, which end, however, in about 10% of people, more 10 to 20%, the two coronary arteries in the back, they're splaying out to all their branches, and they have collaterals, which are little tiny capillaries, arterioles, they go, arterioles, yes, they go between the right and the left side. I'll talk about the significance of that in a second. Again, the right coronary is going around in the atrioventricular area, and that area actually has a name. It's called the coronary sinus because there's a large vein. If you turn your heart over, there should be a large blue vein on the back. Okay, that's the coronary vein, coronary sinus vein, whatever you want to call it. It is the primary return of blood flow from the heart musculature back into the circulation. It opens into the right atrium, just like the two cava enter the right atrium. The right coronary artery, you'll see if you follow it, then goes down the interventricular groove or sulcus on the back wall. And sort of like the anterior descending on the front, that goes down that. So it's a fairly major artery. And it supplies, again, a lot of that septum. And again, that's where it sort of comes that it's a dominant artery. That is the descending branch of the posterior right coronary artery. And the way it comes over there is called often the lateral branch. Now those are way behind the heart, and when we haven't taken the heart out, but I think one of the important things we want to show you is you can lift the heart up. The apex, the heart's suspended by the pulmonary arteries and the aorta, and so you can literally lift the heart up and get to the right coronary arteries. So bypasses can be done to many vessels. Usually, not usually, but they can be done to 4 to 6 little branches, depending on what the disease is. Where the two arteries in the back, where the circumflex comes over, and where the right coronary comes and becomes the descending branch going down between the ventricles, those are where those little arterioles exist. And they're very important because if you have a major blockage of one of the coronary arteries, they will develop into what's called collaterals. Have you heard that term? In other words, like the circle of Willis, you've studied that, it will build up and so flow from one side goes to the other. That's a very, very important thing, especially when there's major arterial blockages. The interventricular septum, again, is supplied a lot by the left at the right coronary artery, but also there are branches going down from the left side. What else can I add?
It's the veins.
Oh, the veins. I'm sorry. Excuse me. Oh, yeah, the veins. Again, on the back of your heart, or one of your hearts. I'll use that. Okay. On the back of the heart, I should have picked that up. Again, that's the circumflex, left circumflex coming around. But also, you see that very large blue vein. That vein, if you follow it around to the front, it runs down in the interventricular sulcus along with the left anterior descending, and that is the great vein. I'm sorry, the middle.
The great cardiac.
No, the great vein.
The great cardiac.
I don't. Sometimes I get even a little confused. That vein is supplying all of this. Draining all of this area. A large amount of the whole left ventricle and some of the right ventricle. Again, it's going around. You're going to find other veins. There's going to be the interventricular one, which is right, again, next to the artery. And then this large blue vein, and it sort of disappears on this model. Let me see if I can get it open. It disappears. But that is the coronary vein. Okay, so that's a very major and important vessel. It doesn't get, the veins really do not get diseased, so it's the arteries again that get the atherosclerosis. But again, that vein comes around and it goes into the right atrium. So you have the superior vena cava, the inferior vena cava, and there's a third opening, maybe some of the models show it, which is where the coronary vein enters. Again, the right coronary artery and the vein over here, that's the middle cardiac vein. And again, I call this interventricular vein, posterior, what is there another term for that?
No, we just
Okay.
call it great, middle, small.
Okay, right. And the small, I'm trying to grab myself. Oh, the small, I'm sorry, right over here. Okay, so blood flow comes back. The veins, the arteries fill during in diastole because that's when the ventricles are pumping the blood into the coronary arteries, and also the ventricular muscle is relaxing. If it were the other way around, you wouldn't get any blood into the coronary arteries. The venous flow obviously is coming all the time around those vessels. The coronary sinus is interesting because angiographers can use it. Again, it has a quite large opening into the right atrium. And if they want to study the left heart or they want to do some type of manipulation, the cardiologist I'm talking about now, and there's blockage that they can't get to the left, they can't get to the left side of the heart, they'll sometimes go in the coronary vein and do a puncture, very, very tiny puncture into the left ventricle, or left atrium, sorry, and right in here, and then they can study the left side of the heart. People who have severe vascular disease, blocked off femoral arteries, aortic stenosis or atherosclerosis, you can't usually use those arteries to put the catheters up. But if those are blocked, and we don't want to use those larger catheters in the arm arteries because of spasm and potential thrombosis, so they can go from the right side to the left side as far as doing an angioplasty or something like that. It's amazing what they can do with these little tiny steerable catheters. The two atria, of course, you're seeing. Again, the left ventricle is primarily, the primary portion of the anterior wall is the left ventricle. The right ventricle, here's the groove coming around. Of course, the left ventricle is some anterior, laterally, and then quite far posteriorly. Again, from the twisting of the heart as it develops. If a person is shot parasternal on the right side, what are you going to worry about being hit? Right, ventricle, is that what you said?
Left ventricle.
No, actually the right ventricle. Again, because it makes up a lot of this anterior surface and fifth intercostal spaces right about where that tack is. So, or if they're stabbed there. Also, if they get shot or stabbed even a little lower than that, they may miss the heart, but you have to worry about the liver because the diaphragm comes up very high to the fifth intercostal space during expiration. Patients, so if the person's running away and gets shot, and or running towards or whatever, and during deep expiration, you can get a liver injury. So you have to be aware it's not only the chest but the liver. Inside, you want me to cover the valves, or would you like to do?
You can do it.
Okay. Is there a little bigger heart? I'll just see.
This one is actually good. Huh? This model is good
This model is good?
for the valves.
Oh, okay.
So you might want to come to the
We'll
side.
check around. There's two sets of valves in each set of chambers of the heart.
It's heavy.
They're the atrioventricular valves. And unfortunately, we won't see these tonight, but maybe if we go to the lab another time, the heart will be out. When we go back and look at the abdomen, and we can take out those the hearts and look into them. The right auricle, the right atrium is right here. And again, the inferior vena cava, superior vena cava go into that, and they sort of have little cubby holes right here, showing them. And if you look, there's a third one, and that's the coronary sinus coming in. The atrioventricular valve, and then you have the ventricular valve. Now on the right side, the atrioventricular valve is the what? Which valve? Tricuspid. Right. There are three cusps, and as Sri has told you, there's an anterior cusp, there's a septal cusp, and a posterior cusp. And again, the papillary muscles the band, all of that is extremely important. If those muscles are injured, let's say a patient has a myocardial infarction, a subendocardial infarction, if that papillary muscle is injured and the tip of it ruptures, then you're going to get reflux back from the ventricle into the atrium. And that's especially true on the left side. It's pretty common with myocardial infarctions and also congestive heart failure where there's a very dilated left ventricle that area gets stressed and you get mitral reflux, which is fairly significant, a problem. Adds to the heart failure. Inside the atrium are the pectinate muscles. Actually, the posterior wall of the atrium and the middle, the septal part of it, is very, very smooth. It has a foraminal valley you can see very clearly. As a matter of fact, if you hold up to the light, when we have the whole heart dissected, both atria, you can see right through the foraminal valley. It's that thin, almost like a thinness of a newspaper. Anyway, in the ventricle, you have the cardiac. I'm missing words today. In the cortical, no, the muscles.
Oh, the muscles.
Yeah.
Trabecular carne.
Trabecular carne. I'm sorry, I missed that. And that's true for both ventricles and for both atria. And then the pulmonary artery comes out, and that is a tricuspid valve. These valves have these stringers and papillary muscles, but there's nothing like that in the tricuspid valves. They're different. These valves need support and need help to open and also, well, when they close, but especially open, keep them under tension. The tricuspid valves are designed very, very nicely, and because of that tricuspid shape, when the arterial flow goes through and the aortic pressure builds up and the left ventricle pressure drops, those three cusps fit together very, very nicely. Unfortunately, diseases are very common of that aortic valve. I'll get to that in a minute. I'm sorry, I was talking about the pulmonary. The pulmonary artery comes out. It comes out actually anterior, as you see here, to the aorta. The aorta starts posteriorly, again with the twisting, but very quickly the aorta becomes anterior, and the pulmonary valve and then pulmonary artery, and then the left and right branches, especially the right, goes behind, and again the aorta becomes anterior, and it then and the arch, of course, dives posteriorly into the posterior mediastinum. So on the left side is which valve? Atrioventricular mitral, right? And it has how many? Two. Okay. It has again the same muscles, the same papillary muscles, and also the chorda tendineae. The aortic valve, as I was trying to get to, and I'll get to it now, is the site of a lot of disease. As a matter of fact, it's the primary site of aortic disease, of heart disease as far as valvular disease nowadays. In the past, when rheumatic fever was very common, streptococcal infections, we didn't have the immediate care centers right around the block that could do an instant strep test and put the patient on antibiotics. So people got a disease called rheumatic fever, came on a couple of weeks after the episode with the pharyngitis. And that caused via immune responses and immune protein antibodies building up, a lot of systemic disease. One of the systemic disease affected the heart valves. In that case, it was mostly the mitral valve that was affected, causing mitral stenosis or regurgitation. So we don't see that disease in the United States or Britain or areas like that. In undeveloped areas, however, rheumatic fever still goes on if again, unavailable medical care. What we see now, and the reason I said the aortic valve is the most likely cause, is we see stenosis or sclerosis of the aortic valve. And it occurs with age. And of course, my generation, the baby boomers, we have a lot of people that are aging. So there's a significant amount of aortic stenosis. It can be aggravated by certain other things, cigarette smoking, and other things. But again, just aging is going to cause the valve to get very, very stiff. And also, as it does that, it will usually get calcific material on the cusp of the valve. Once those valves are that stiff, needless to say, they do not open very well. And that's why aortic stenosis is a major problem. Another group of people that get calcifications of their aortic valve is the congenital anomaly of a bifid aortic valve. Instead of having 3 cusps, there are just 2 cusps. And so there's more turbulence, and they can get that aortic sclerosis and stenosis at a much earlier age. As far as surgical aspects, as far as the heart, you all know about coronary artery bypass. You know about angioplasty and stenting. Angioplasty was the originator as far as any invasive cardiology, and it's good. It works very well. However, what it does, what do you think it does when it blows up in the coronary artery and there's a blockage there? What do you think it does to the artery? Just blowing it up with a balloon.
Stretches it.
What?
Stretches it, so it doesn't. It stretches it.
Stretches it, yeah, and actually injures it, and injures the endothelium especially, and that's how actually atherosclerosis starts, with injury to the endothelium, if you look back to the origin. So the problem with just angioplasty is high rate of restenosis, usually within 2 years, at least 50% or more. So then the great mind, people came together, engineers and doctors, and they developed these stents. So stent is like a little chicken coop, little piece of wire. You can go online and see what they look like. It's on the outside of the balloon, so they'll dilate up the vessel, as it's done, that little piece of wire opens up, and then they can deflate the balloon and take the catheter out. So there is actually something holding the artery open. Of course, there's going to be injury to the artery. However, using that technique, the arteries will stay patent for a much longer time. Eventually, and all the clinical studies have showed that angioplasty stents, they are still inferior to coronary artery bypass, especially using the internal mammary artery. When we go in there, I'll show you the internal mammary artery and how we use that for coronary artery bypass. And valvular repairs nowadays, valvular repairs started primarily with very mechanical valves. Everything from a little ping pong ball in a cage that went up and down. Those patients you could hear from across the room because they have a click. You would hear audibly the click from across the room that little ping pong ball hit. Problem with those is they wore out, and thrombus and all other problems. So they've gone more to the preferable is to use a bovine or a pig valve, so a xenograft. That tissue, especially in the pig and somewhat the cow, are very close to what we have. There are also other valves that are types of plastic, Teflon, whatever, that just flap open like a trapdoor type. They're a little better than that ball valve apparatus. The other thing that again, we're doing more and more non-invasively, is that now, especially with aortic stenosis and mitral, invasive cardiologists are able to dilate those. Sort of like if a person has a stenosis in their esophagus from GERD, a contracture there, they can put down in the catheter a fairly large balloon, and they can stretch and dilate. Again, it's not just a matter of just stretching it out, and you have to do it very carefully. The pressures have to be monitored very well. And with any procedure like that, there's a chance the calcium or one of those excrescences, little lambda excrescence, can break off and go as an embolism as far as a stroke. embolism. Of course, coronary arteries, the first arteries, really going up, straight up. So, is that okay? Okay, sorry if I took too long. But look at the coronary arteries, look at the valves, and the atria, sort of get an idea about that. Where's the anterior surface of this heart? Is there one? No?
I think that's how the model is, I think.
Oh, good. Let me just go 1 second longer. And be sure you look at the sulci, the interventricular on the front and the back, and also the coronary sulcus where the coronary vein is at. This model is sort of an artist's rendition of how we do bypasses. These bypasses go into the aorta and down to the coronary vessels. Obviously, they're going to bypass to a patent vessel where the blockage is more proximal. These would be reverse saphenous vein grafts. We take the saphenous vein from the thigh. You want to, of course, reverse it because otherwise those valves are going to block off the flow of blood. And you do anastomosis to those two. I mentioned the internal mammary artery. What's done is the internal mammary artery runs parasternal all the way up and down, one on each side. And then anastomosis actually goes down into the abdomen and reaches even down to the deep epigastric vessel coming up. But the point is you can clamp the internal mammary artery with impunity at the bottom of the sternum. You can then dissect it away, put little clips on the branches, and you have and it's coming from what blood vessel did you study yet? Internal thoracic or internal mammary?
So it's the same thing.
It's the same
What?
thing. It's the same thing, yeah.
What?
The memory and.
Internal mammary, internal thoracic are the same blood vessels.
Right. It comes from the subclavian artery. But anyway.
I mentioned this briefly today, this morning. Internal thoracic comes from first part of subclavian artery.
And then you can bypass using that artery as a native artery, and that has the best patency as far as long-term patency. So cardiac surgeons nowadays always want to try to do one of the bypasses with the internal mammary artery to get some long-term patency.
So the internal thoracic artery is here, right? And it comes from subclavian. So if I cut the lower end of the artery on the left side and attach it to the artery that is blocked, distal to the block. Here's the artery that is blocked, right? I'm going to cut the lower end of internal thoracic and attach it to the artery distal to the block. So what's going to happen now? Left ventricle pumps blood, goes into arch of aorta, left subclavian, left internal thoracic, back to heart. Do you see that happening? So this is good. Now I'm trying to attach an artery of similar size, like coronary artery, to an artery. And if you need multiple bypass, of course, you're going to take the great saphenous vein, cut into many pieces, and then attach it different points. What's going to happen to the vein? Eventually, the vein will become an artery. Histologically, the difference between an artery and a vein is the middle layer has more muscle for an artery, and the outer layer has more connective tissue for a vein. And because now you're transplanting this vein into a high pressure area, right, for an artery, it will eventually change into an artery, histologically. It will become an artery. And there's one other thing Dr. Pulsin mentioned is, the flow of blood through coronary arteries is during ventricular diastole, right? Not during systole. Do you know how that happens? It's called the effect or Wind-Kessel effect, right?
It sucks back into the coronary opening.
Oh.
Diastole.
What's that?
The sinuses of the aortic valve.
What is aortic sinus? What is aortic sinus?
Oh, it's the back sinus.
The upper surface of the valves. You're right. Right? So here is the ventricular septum, left ventricle. Here is aorta. Here is right coronary artery, left coronary artery. These are the valves. Right? And the ventricle contracts, blood is pushed in to the aorta, and the blood goes up. When the ventricle relaxes, the pressure below is lower, obviously, so the blood will try to come down. And when it comes down, the valves will close. Because the valves are curved, there is a depression above the valves, and that is the aortic sinus. So blood will fill up these depressions and then start to flow through the coronary arteries. and that's called the Win-Kessel effect. Okay, so ventricle contracts, blood goes up. Ventricle relaxes, blood is trying to come back down, but the valves are closed now, and that results in the depressions above the valves getting filled up with blood, which will eventually, immediately flow into the coronary arteries. And the reason for this is we need to have blood flow through coronary arteries when the myocardium is relaxing. If this is the myocardium of the heart, I have an artery running through it. What's the point in having blood flow through this blood vessel when this is contracting? It's going to squeeze that blood vessel, which means the myocardium will be ischemic. So blood flows through coronary arteries only when the heart is relaxing. Right? Was one thing. There was another thing I wanted to mention, I forgot.
Just one thing, the nerves.
Sorry.
This model, does anybody else have a model like this? Well, you might look at the pictures, I can pass this around. But the neural system of the heart is made up of cells that are the same as myocardioplasts, myocytes, but they differentiate more into a conducting system, and some of those actually more like nerves, and some of those actually make the nodes that are sort of the jump start or the batteries that send out the signals. The first node, and you so have to tip it like that, is called the sinoatrial node, and that is usually the fastest signal. So it's a supremacy in most people, 60 pulses or higher. And so that is the generation of in a normal healthy heart of the first part of the heartbeat. The signal, the electrical signal, then does not have a discrete path, but it goes, and you can see there are a bunch of lines like spiders in there. It goes throughout both atria, all around both atria, no specific conducting pathway, and then it winds up just in what's called the membranous part of the interventricular septum and also the atrial septum, and just right at that point in those septae is the atrioventricular node, which is a sort of a boost, I guess a boost station, whatever. It can also take over if, for some reason, the sinoatrial node wears out, and that actually happens a lot as we get older. As people age, there's sort of a senescence of that node, and the first sign of that is that the atria, all these little areas in atria, start contracting and sending pulses and just all over. What do you think that's called when it looks on the EKG? AFib. AFib, right? Exactly. So the first sign sometimes of the wearing out of the sinoatrial node is atrial fibrillation in an older person. Anyway, I don't see, they didn't really depict a atrioventricular node if you look in your books. By the way, you won't see these structures. I won't see these structures. They blend in right with the musculature. They're embedded deep. And the way we know that there, of course, is with fixation and looking at specific dyes and stains. And also now we do electrophysiology where a little catheter, a little probe, can actually measure potentials and can map exactly the pathways that are coming from those nodes. But there is that atrioventricular node. It then has a fairly definitive, sort of thicker characteristic bundle coming out of it, and that's called the bundle of His, HIS. That then breaks quite quickly into the right ventricular bundle, and the left ventricular bundle. The left is a little bigger than right, as you expect with a bigger, myocardium and everything else like that. So you hear the words right bundle branch block, left bundle branch block. What do you think complete heart block would be? A little louder, I can't hear. Louder.
Lack of the whole.
I'm sorry, are you saying that?
Go ahead.
And basically the signal is not getting from the atria to the ventricle. The
atrioventricular node is not conducting at all, that part of the system. And how does that happen? Sometimes, again, with aging, changes in the heart as far as, disease, heart failure and everything, and of course, myocardial infarction. And one of the reasons, again, we talk about the dominance of a particular artery is what blood flow is going to the interventricular septum, especially is covering those two areas, especially the atrioventricular node. So the book has it a little clearer. Again, we can't see this when we're dissecting the cadaver. You wouldn't see it if you dissected a fresh cadaver either. It's just something that's there. Any question about that? Or okay. So a lot of the terms that we use clinically that you'll work with come again from the anatomy. The anatomy of the heart, like any other thing, but especially of the heart, I think, is integral to disease. And what's the number one cause of disease in the United States? Heart disease or vascular disease, atherosclerosis. It still is right now. It may be surpassed by cancer in the next, or maybe close to it now, but it is still the number one. So that's the importance of it, knowing your anatomy. Thank you.
Okay, AV valves open downwards and the semilunar valves open upwards, right? Semilunar meaning pulmonary and aortic. And what is the outflowing part of right ventricle known as? The outflowing part, each ventricle has a rough portion and a smooth portion, right? The rough portion is inflowing part, the smooth portion is outflowing part. On the right side, right ventricle, the right side will be rough, left side will be smooth. While left ventricle, right side will be smooth, left side will be rough. Because the inflowing part is close to midline. For the right ventricle, the outflowing part is known as infundibulum. Infundibulum continues as the pulmonary trunk. On the left side, it is known as aortic vestibule or conus arteriosus, whichever term you are used to. Conus arteriosus is actually a term that we use in embryology, not in gross anatomy, but some textbooks to use that term. So the aortic vestibule or the conus arteriosus is the outflowing part. Anyway, I think we'll go to the cadaver lab and look at the lungs, the thorax in general, everything in thorax.
What did you say?
The only reason they would ever use that word is if the you made it sound like
Well,